on its face, you could maybe draw some more simplistic conclusions about Black medical care because of just socioeconomic status, right?
Hmm.
Because there is this massive wealth gap that has persisted for so many years or centuries and decades, that is the sole root. But you cite a bunch of really high profile examples, the most recent one being Serena Williams, speaking about how she was not taken seriously when she had symptoms that were, I think, like her previous blood clot during her pregnancy, if I'm not mistaken.
Yes,
Yeah.
correct.
And she was calling attention to this, and she almost died in her
Yes.
pregnancy because of that. And she has so many resources. She's a millionaire. She's one of the greatest athletes in the world. So, it's not just socioeconomic status. It's also just like
Right.
Black pain's not taken as seriously, and Black female pain is not taken that seriously.
Yeah, no, exactly. One thing I always quote is like this idea that, here I am as a Black woman physician with a Harvard undergrad degree, a Harvard med school degree, but I'm still 5 times more likely than my white peers to die of pregnancy-related complications. And you would say, okay, wait, so why is that? Like, why is that the case? I have access to, insurance. I should have access to quality care. But the other piece of it, in addition to how racism impacts what we call the social determinants of health, like housing, education, just basically depriving communities of resources that ultimately impacts health. The other part of it is what happens when Black patients interface with the healthcare system and health professionals. And this idea that it really doesn't matter what your socioeconomic status is that, often our concerns are minimized or ignored or dismissed. And so we see that actually a lot, regardless of socioeconomic status. And, I think most health professionals would like to say, no, I treat all my patients well. I treat them all the same. But unfortunately, what we're seeing is that really is not the case. That exactly, you mentioned this whole issue of pain and pain inequity, and that how often, there was a study in 2016 out of UVA that showed that medical students and residents with 2 mock cases, the only difference was the race of the patient. They consistently scored the Black patient's pain lower.
Yep.
And gave the patient less pain medication. So that's 2016. So I always say in the book, because there's a lot of history in it, a lot of these myths about Black people being biologically different, not feeling pain, are deeply rooted in the history of our country's racism, Jim Crow, and it persists today in our healthcare system.
I cite that exact example a lot because it's the one that sticks in my mind. I believe that study also in that survey of those medical students found these really racist tropes that they still like,
I,
that Black skin is thicker than white skin, for example.
Yes, I know. Yeah, I was like, I didn't want to answer your question too long, but yes, I'm so glad you
No,
brought
no.
that up. So the authors like made up these myths, right? Yeah, like Black people's skin are less sensitive to pain, or yeah, Black skin is thicker. So and they found that those medical residents and medical students who were more likely to believe in those false myths were the same ones who were more likely to score the Black patient's pain lower and undertreat the Black patient's pain. So I like to say this, that like health professionals are no different than anyone else who lives in our country, that they are also absorbing this cultural messaging that we have all around us, in the media, in books, in all different places, about anti-Blackness and how Black people are somehow different. And unfortunately, very unfortunately, that actually impacts how we are caring for patients.
Right, right. I mean, it's amazing, and how that myth, how those same folks, medical students, despite going to undergrad, having this understanding, they buy into that, and you just show how deeply rooted it is.
Right. And can I add one
Sure.
thing? Oh,
Yeah.
so, like, I know I talk about in medical school, like explicitly or implicitly, sometimes, we're taught that there are differences. Like for a long time, there was a race correction factor that was associated with kidney function. There was a different set of normal values for Black patients and non-Black patients. Like if you go into the electronic medical record system, you would see different ranges. And that was based on old myths that Black people had more muscle mass, and that correlated with a different set of kidney function. And so actually what that led to is actually Black patients having a delay in being referred to for specialty kidney care and being placed on transplant lists. So that race correction factor, a lot of kidney groups have been working towards getting rid of that. But we see how, these differences based on these myths actually end up harming Black patients.
And it essentially boils down to race essentialism, right? It's
Exactly.
this idea that people are inherently different biologically in some way based on race. I'm wondering how you feel, and I don't have the knowledge really to go to make an assertion here, so I'm going to ask for your expertise on sickle cell, because there's a real lack of research and treatment, is my understanding, for sickle cell, or an analysis into the potential connection with past instances of malaria. That's something I had read previously, but I'm curious what your take is on that kind of debate.
Oh, sure. And I think I would preface this by saying, when we see these poor health outcomes, even among patients with sickle cell disease, really what they are the impact of racism, right, through practices and policies, and not race. So, for example, with sickle cell disease, even it's a gene, it's an inherited disease, right? So it's based on a gene. So it has, there's geographical ancestry related to it. It's not race. And one thing I talk about in the book is that there are people from all over the world that have sickle cell disease. A lot of them are from sub-Saharan Africa, but a lot of them from the Mediterranean, from India, also have the sickle cell gene. And the issue is that in the United States, most people with sickle cell disease are Black. Right. So 100,000 Black people in the United States have sickle cell disease. And so because of that, it's been racialized as a Black disease. So even though the disease it's been discovered over 100 years ago, and yes, it does have a protective factor for malaria. There's a reason why people in those different parts of the country, I'm sorry, of the world rather, have this inherited gene. It's supposed to be protective against developing malaria. But at the same time, because it's been racialized as a Black disease, in the United States, we have seen a lack of research into therapeutics, lack of funding going into developing sickle cell centers of excellence like we have for other inherited diseases like hemophilia or cystic fibrosis, which primarily affect people who are racialized as white. And so because of that, we see a lot of patients with sickle cell disease coming to the emergency department because there is not a system in place to care for them appropriately, so that to prevent these ER visits, we see them in the ER. And what happens is they get stigmatized. They come in with pain crises and they get stigmatized as drug seekers, like they're seeking pain medication, and they get characterized as people who are, you have to be suspicious of, who are just there because they're addicted to pain medication. And really what it's a result of we don't have a system in place outside of the ER because of the lack of funding to care for these patients. And so it's almost like it's compounded. It's these issues are compounded on each other.
Right.
And so that's the experience. I talk about this patient I had with sickle cell disease in my book, who just, came to the ER so often. And we saw so many patients like that in my residency, which is based in a mostly low income, working class Black neighborhood.
And the lack of preventative care is also going to compound anything else that comes up. And
exactly.
I guess that brings us kind of to where I wanted to conclude, which is maybe our most recent example of extreme medical racism and lack of care for Black people in this country, which was the COVID pandemic, and who bore the brunt of the pandemic, who was asked to make sacrifices to keep the economy going and who was not.
Right.
I know that was a big part of your inspiration for the book. If you could talk a bit about that, your experience as a doctor during that time.
Yes, absolutely. I had made kind of a career transition at that time. I moved from ER to urgent care in January of 2020. And then March happened and I was, working in Brooklyn, New York in the epicenter. And I was at an urgent care where we saw a very racially diverse patient population, but literally within days, I saw a quick shift in who I was caring for, mostly essential workers, service workers, mostly Black people and people of color. Most of my white patients I did not see. Many of my patients like worked for the MTA, you know, the subway and bus service. They were coming in with COVID symptoms. And I remember thinking, even before the pandemic hit New York City, seeing the risk factors of high blood pressure, diabetes, obesity, asthma as risk factors for people who do worse when they get COVID, I said, oh, I'm so worried about our communities because I know our communities carry a higher burden of those chronic disease because of systemic racism. And so I actually wrote an op-ed before the end of March about what I was concerned was going to happen. And of course, you know, it did happen, but it just kind of exposed already the very deep fissures that we have within our healthcare system as it relates to access to healthcare, as it relates to, you know, employment. Like, we know that people in essential jobs or as service workers, you know, low-paying jobs, were more likely to be interfacing with the public and exposed to the virus, and also less likely to have employer-sponsored, especially service workers, employer-sponsored healthcare. So again, even more at risk. We know that people of color were more likely to live in multi-generational housing. Again, more at risk, more likely to take public transportation. So I thought it was really unfortunate. It was very unfortunate, though, but to show like this how the pandemic really to use it to connect the dots to show how systemic racism impacts those social determinants of health and leaves our communities so much more vulnerable for when a pandemic hits.